Good evening, everyone. Welcome to the fourth and final session of the Diabetes Update webinar series. Today's webinar is called, Can This Be Done? Deprescribing Insulin, and is brought to you by the Physician Learning Program and the Office of Lifelong Learning in partnership with Diabetes Canada Edmonton and Area Professional Sector Chapter. I'm Dr. Roshan Abraham, a family physician and an assistant professor in the Department of Family Medicine in the Faculty of Medicine and Dentistry. The Office of Lifelong Learning is committed to providing the latest information, advice, and resources to support continued educational needs of healthcare professionals and their teams. Just before we begin tonight, I would like to go over some housekeeping slides. We acknowledge that we are on traditional territories across Canada of the many First Nations, Métis, and Inuit whose footsteps have marked these lands for centuries. I am pleased to introduce our three speakers for tonight. Dr. Rose Yeung is a clinical endocrinologist and associate professor in the Department of Medicine at the University of Alberta. Her research interests include diabetes, quality improvement in healthcare, and implementation science. She is a medical director for the Office of Lifelong Learning at the University of Alberta. Dr. Yeung is passionate about patient education and empowerment, co-founding the Edmonton Zone Diabetes Resources Review Committee, board member of the Type 1 Diabetes Think Tank Network, a consortium that brings together patients and healthcare providers to break down communication barriers and inform more humanistic practice, and co-creator of the educational website, diabetespregnancy.ca. She values broad community engagement and was the 2018-2019 chair for the Edmonton Area Professional Section of Diabetes Canada, and is a core committee member of the Alberta Diabetes, Obesity and Nutrition Strategic Clinical Network. Dr. Darren Lau is an academic general internist and diabetologist at K Edmonton Clinic. He completed a PhD in clinical epidemiology in 2012 and his general internal medicine residency in 2019, both at the University of Alberta. He attends clinical teaching unit at the University of Alberta Hospital and has a modest outpatient practice consisting of people with complicated diabetes. In his research life, Dr. Lau uses administrative databases to develop insights about the outcomes of medical care in people with diabetes. And lastly, Dr. Donna Manca is a family physician and professor and director of the research program in the Department of Family Medicine at the University of Alberta. She is the director of the Northern Alberta Primary Care Research Network, or NAPCRN, a network contributing data to the Canadian Primary Care Research Network, or CIPS. NAPCRN extracts information from electronic medical records, cleans and structures the information for the purpose of quality improvement, surveillance, and research. Dr. Manca's research interests include primary care, implementation science, privacy, ethics, research networks, cancer and chronic disease prevention, screening, and management. She is a Diabetes Action Canada investigator contributing to the National Diabetes Repository. She is also a medical director of the Physician Learning Program and the medical director of the Better Training Institute aimed to improve chronic disease prevention and screening across Canada. I now turn it over to you, Darren, to get us started.
All right. The theme of today's talk is deprescribing insulin. Again, I'm Darren Lau. I'm one of the academic internists at the University of Alberta Hospital. It's my pleasure to be here speaking to you today again for the third week in a row. And looking through the attendees list, I see a number of folks who, number of names I recognize from multiple previous sessions. So it's wonderful that you've been able to join us every week for 3 straight weeks, some of you. So our thanks. Anyways, right. So it's long been a thing, a held belief that diabetes progresses, people end up on insulin, and it's a one-way street. And just in my own practice, I see a lot of inertia around people being on insulin, and then those blood sugars are still doing something funny. What do we do next? There's this reticence to think about, well, can we turn off the insulin? Can we decrease the dose? Can we try other insulin-sparing agents? So that's the point of today's talk, is what can we do to deprescribe insulin in the appropriate patient? So here are today's objectives. We're going to begin with a little bit of a recap of the last couple of talks we've had, and then we're going to move on and talk a little bit about prescribing practices evident in Alberta. And then we're going to come to objective 2, so understand why and when to deprescribe insulin. And then objective 3 is the practical one. We hope that by the end of this talk, you'll be ready, you'll understand which patients would benefit from deprescribing, and you'll feel empowered to do so. And as always, we've got some tools for you. All right, just a reminder, of course, that this is the 4th talk in a series of 4. So there you have it. If you want to see the previous talks, they're available. I think they're actually YouTube links, but you should have them in your email. So just some follow-ups from last week. We had a number of questions that we thought we'd save for today to answer. Question 1 on the list was someone pointed out, well, what do we do for a patient who develops retinopathy when we start the GLP-1 receptor agonist? As it turns out, I happened to meet a retinal specialist last week, and the retinal specialist said, well, just get those blood sugars better. Because from an ophthalmic perspective, good blood sugars is good for the body. It's good for the eyes long-term. This particular specialist has not seen an epidemic of treatment-induced retinopathy from GLP-1 receptor agonists. I don't think he was able to identify a single case he thought was due to the GLP-1 receptor agonist, actually. And so he says, don't let that weigh too heavily in your decision-making. Another question we thought we'd address from last week, a holdover. Someone asked if there was specific evidence for a combination of SGLT2 inhibitor and GLP-1 receptor agonist. We did a quick look through literature, and there are in fact multiple trials that have shown additive HbA1c reductions that you achieve when you add on that GLP-1 receptor agonist in an SGLT2 treated patient. So Sustain 9, for example, showed additional weight benefit, blood pressure reduction, and HbA1c further lowering of 1.4% when semaglutide was added on to patients who were already on a GLP-1 receptor agonist plus or minus other agents. And of course, this was a high quality randomized, placebo-controlled randomized trial. I do counsel my patients when I'm using combination therapy this way on features of hypoglycemia to watch out for. These medications are safe, but it's about what else your patient might be taking if they're on a sulfonylurea, for example. I'd like to point out that both classes of agents, SGLT2 inhibitors and GLP-1 receptor agonists, have been used in adults who don't even have diabetes. All right, I'll take the next slide. The last question I thought we'd come back to from last week, we were asked a question whether there were ethnic differences in the efficacy of GLP-1 receptor agonists. There is a systematic review out there suggesting no cardiovascular benefit of GLP-1 receptor agonist in Black adults, but I don't believe it for an instant. I think the field as a whole suffers from really tiny numbers of minority groups being enrolled in these big CV outcome trials. I think it just happened to be the case that the trial that had the most Black patients in the systematic review happened to be of a GLP-1 receptor agonist that had no cardiovascular benefit for any group. So it's a matter of a little bit of confounding within the meta-analysis, if you will. If you look at the Sustain series of trials, for example, and you meta-analyze the whole series of trials, you can see some of that data on the right-hand panel there. There really is no evident difference in terms of the glucose benefit and weight reduction among groups by ethnic minorities. And if you look at the Sustain 6 cardiovascular outcome trial, that would be, of course, the CVOT of semaglutide. Again, small numbers, so big confidence intervals for the minority subgroups, but it sure doesn't look like there are any systemic differences there either. And that would be the lower panel there, would be the Sustain 6 subgroup results. Yeah, right there. Yeah. Okay, so we'll move on from that. That's just a little quick touchdown of some unanswered questions from last week. But anyways, the topic of today, again, is deprescribing insulin. But deprescribing depends on having an alternative agent to replace the insulin with sometimes. The newest ones are SGLT2 inhibitors and GLP-1 receptor agonists, of course, and I've actually taken to calling them in my own practice. I call them insulin-sparing agents for a lot of my patients. And so this is a brief recap of some material we covered in the previous two talks, okay? So both SGLT2 inhibitors and GLP-1 receptor agonists reduce glucose, they reduce weight, they give you systolic blood pressure benefits, they are safe, and they provide cardiovascular and renal, especially in the case of SGLT2 inhibitors, they provide cardiorenal benefits. Your GLP-1 receptor agonists, of course, have very potent glucose lowering and weight reducing effects. For SGLT2 inhibitors, the major side effect to watch out for, the most common one, would be yeast infections. Don't forget your sick day counseling, and that's to avoid diabetic ketoacidosis and hypotension. I'll take the next slide. For your GLP-1 receptor agonists, the most common side effects tend to be gastrointestinal. You do need to counsel your patients, even in under ideal trial conditions. About 10 to 15% of patients at least have too much difficulty with the gastrointestinal side effects to complete the titration or to continue their therapy. So it is something to expect, to watch out for, to let your patients know as well. Okay, it's not a failure, it just happens. That's just the way it goes. Do watch out for patients who present with acute pain because very rarely you do have some gallstone issues. I'll take the next slide. Okay, so this is from the Diabetes Canada guidelines now, the 2020 update. And again, it's a reminder, well covered during the previous two talks, but yeah, you've got the menu of options available to you. If you need to lower blood sugars, that's the right-hand stream there. But as a reminder, the key point from this slide is the left-hand stream there. If your patient has a cardiovascular condition or chronic kidney disease, or cardiorenal indication for a GLP-1 receptor agonist or an SGLT2 inhibitor, then you really do want to get them on one or both of these agents. Again, not for the glucose lowering necessarily. I mean, if they need glucose lowering, that's wonderful. But even if they don't, you should get them on one or both of these classes of agents. And that's because the purpose here is for the end organ benefit. Okay. So that's a brief recap of the previous couple of talks, and I will I think it's Rose who's going to talk a little bit about the prescribing patterns. Oh, Donna.
Yeah, I'm going to talk about napkin. So this is a slide that tells you a little bit about the Northern Alberta Primary Care Research Network, called napkin for short. It's a practice-based research network, and family physicians and primary care providers in Northern Alberta are participating. We extract and clean and structure the electronic medical record data for the purpose of research, surveillance, and quality improvement. And by participating in practice-based research networks, family physicians and primary care providers can contribute to meaningful research done by themselves and their colleagues. This table illustrates how the data obtained from the network can inform family physician and primary care providers about the characteristics of the diabetic patients in their practice or in the network. And you can see that over 60% of these diabetic patients are obese, for example, and 43% have a hemoglobin A1C of 7 or greater. We do not appreciate this kind of information when we're stuck in the trees. That is when we're seeing our individual patients, and we're often not aware of what the entire practice can look like. Data at the practice level is important to better inform us, and then we can appreciate the forest and the areas that might need our attention. So to provide comprehensive care and improve practices, we need both levels of data, that is individual patients and the practice level. Next slide. So this slide illustrates the network data, the prescribing practices of the primary care providers participating in NAPCRIN. And you can see that a lower percentage of patients with cardiovascular disease, heart failure, or kidney disease are being prescribed the drugs that we think are of interest, the SGLT2 and the GLP medications, when you compare them to the patients that do not have these conditions. And you may recall, we want to use these medications in patients with these conditions. So what's happening here? You could also notice that maybe a higher percentage of the patients with cardiovascular disease, heart failure, and kidney disease are prescribed insulin. And when I think about myself, I often am very hesitant to prescribe new medications when I have patients on insulin, especially diabetic medications. I'm uncertain how I can do this safely, and I need information on how to approach this. So is it possible? How can we deprescribe? And I think Rose is going to help us with these questions.
All right. I'm just going to introduce the motivating case for the day, as always. It's nice to think about a particular patient. Thank you very much for that run through of the data, Donna. And anyways, okay. So today's patient is Maggie. Maggie has long-standing type 2 diabetes, for which she is presently on Janumet and gliclazide immediate release 80 milligrams, and she's on insulin glargine or Lantus. She takes 40 units every evening. She has hypertension, for which she's on perindopril and hydrochlorothiazide, and for cardiovascular protection, she's on aspirin and atorvastatin at the 20 milligram dose. You bring her in to talk about her diabetes, to review things, and this is what you find out. This is what you notice. Her blood pressure is 130 on 70, so that's pretty good. Her BMI is 30, so she's overweight. HbA1c is 8.0%, a little ways to go. eGFR is 55, so she has chronic kidney disease. And her triglycerides are 3, and her LDL is 3 as well. The fascinating thing, though, is that Maggie points out that once or twice a week, she has symptoms that she wonders might be a low blood sugar. So you ask her for her blood sugars. I'll take the next slide. These are the blood sugars she provides you. She gives you 2 days worth of measurements. Again, that HbA1c is 8.0%. On day 1, her fasting blood sugar was 3.8, so it was definitely low. By noon, her blood sugar had increased to 16.2. At supper, it was 12.2 on that day. On day 2, she started off with a much better fasting blood sugar, as 5.2. And at noon, her blood sugar was 10.2. By evening, it was 9.3. So take a moment, have a look through those blood sugars, think about the case. Take a moment, yeah. And so the way we're going to discuss the case, as in previous sessions, is going to be a roundtable type format where we each present certain, oh, there's something going on in the chat here. We are not seeing the blood glucose slide. That's a bit odd. I wonder, Kathleen, if you're able to put on the chat whether you see it now. It's the blood sugars are really in the panel on the right, upper right square at the bottom. Okay, good. Okay. Gotcha. Yeah, okay. So the slide looks very similar to the previous one. Maybe that was the issue. I'm not sure. Anyways, yeah, so we'll do a little bit of roundtable discussion where we go Donna, myself, and then Rose, and just share some thoughts and perspectives, okay? Meanwhile, I encourage anybody in the audience to think about particular cases that they have in mind, and because ideally this is a very practical day. Okay, Donna, thanks.
Yeah, thank you. Yeah, so a bit of a conundrum with this patient. You know, she could be on too much insulin overall, and you do get these episodes of hypoglycemia. But I'd like to know what the pattern is to those episodes. You know, when are they happening? Are they, related to meals? What time of the day? Is it in the morning? Is it related to certain activities? It's important also to think about what she's doing, like is she eating, pop and wine or beer at the time, because I've had patients, they have high sugars and then low sugars related to, diet, and they may be getting some hyperglycemia as well. So important to think about thirst and symptoms of hyperglycemia, that the patients may not be disclosing to you. So I find it really important to ask. Next slide. With this patient, I find her, a lot of history is missing for me because I don't know how she wound up on the medications and what I suspect might be a high dose of basilar insulin, so I thought I'd share this information with you in that I often, when I'm prescribing insulin, I use point of care resources. So I often go to UpToDate as a point of care of comprehensive medical resources. And this is just an example. They have a number of algorithms, and it can guide you in when you're initiating insulin and what to do when certain situations arise. With this patient, I suspect what might have happened, maybe she's seen one of my colleagues and is coming to see me now, and I don't know the history, so I'm looking at just this snapshot and thinking, did my colleague just focus on treating the high hemoglobin A1C and not maybe checking blood sugars at different parts of the day? There's a danger, I think, in only treating hemoglobin A1C, as you're not seeing the entire picture. And that could be why we're in this predicament, but it could be other things as well. Next slide. So my suspicion with this patient, with the brief history I have, is that she's on too much insulin. She's getting low fasting sugars and some hypoglycemic symptoms, and they're happening a few times a week. So that's a bit disconcerting. Sometimes you'll get patients, that have a similar picture, but don't complain of hypoglycemia. And those patients, I'd also be worried about them having episodes in the middle of the night, particularly when they're taking evening dose of insulin and not eating. You know, they can eat a hypoglycemic episode in the middle of the night and then wake up with a high fasting sugar, and you think you need to give them more insulin, which is kind of dangerous, you know. So when I see these kind of pictures, I might have patients take an alarm clock to bed and wake them in the middle of the night and check their blood sugar to make sure that's not happening. I also have concerns with this patient's diet because she's eating a lot of processed foods. They could be high in carbs. And I'd ask her to connect with both my PCN dietitian as well as my diabetic nurse for more teaching, because in appointments, we don't have a lot of time for that, and we need the team to help us. With Maggie, I would like to start her on an SGLT2 inhibitor. She has some kidney failure, and I would stop the sulfonylurea. I don't think that's really good for her. She's obese, and I think other treatments are better for that. I worry about her insulin dose. So what would I do in a pinch? Well, I go to UpToDate, that resource, and what it would suggest, there is an algorithm for the hypoglycemia, and if it says it's mild with this insulin, you could reduce by 4 units or 10%, but hers isn't mild. She's got more frequent and more severe, and in that case, it says it's more prudent to reduce substantially, and they say 20 to 50%, you know, and then repeat titration slowly. I'm going to turn to Darren for more help on this. And the other thing, though, I would advise her is to watch her blood pressure more at home. And if it starts decreasing, I'd consider stopping the thiazide. So next slide.
Yeah, I think I totally agree with you, Donna. And I think one of the key messages here is just because this patient is on insulin doesn't mean that's it. We do need to consider the other agents and organ indication here for an SGLT2 inhibitor. The question is, okay, how do we do this safely? Because the most concerning feature that needs to be addressed up front for this patient is in fact the hypoglycemia. I totally agree. The culprit here, of course, because she's having multiple events and it's fasting hypoglycemia is what you see in her blood sugar records. The culprit here is probably the insulin lantus. That's the glucose lowering agent that's on board in the wee hours of the morning. There are a couple of other observations from just these 2 days of blood sugars that are worth mentioning. One is that the blood sugars are actually higher on the day where she has the low. You see that noon blood sugar is 16.2 compared to 10.2 on day 2. So there's an element of hyperglycemia here that might be driven by the low, or at least by the need to ingest fast-acting carbohydrate to treat that low. And whenever you see high blood sugars and there's this hint that things are really, really variable, we just have to be careful not to mistake this reactive hyperglycemia as an indication for more insulin, which would make the situation a little worse. Okay. And the other observation here is that the average blood sugar on both of these days is probably about the same. So the HbA1c you'd get if either day were the norm for this patient would also look about the same. But day 1 with the huge glucose variability is really concerning, and glucose variability is just something you don't get with an HbA1c. Anyways, okay, so 40 units of lantus is probably too much for her. She is what we would call over basalized. So her lantus titration has taken her to a dose that's too high for her. All right, I'll take the next slide. Okay, so this is the normal physiology of insulin secretion from the pancreas in reaction to a carbohydrate load, a meal, for example. There's 2 phases of insulin secretion. There's the first phase response, which is that first 30 minutes, it gets the blood sugar down because when you eat a load, of course, it spikes. And then there's the second phase response. That's the one that takes you out a couple of hours afterwards. It keeps the blood sugars down. And you'll notice that the profiles of the peaks, the width, they vary depending on the type of food you eat, how fast it's absorbed, etc. I'll take the next slide. In type 2 diabetes, one of the first problems we typically see is the loss of the first phase insulin response, and that allows for high and prolonged glucose spikes after a meal. The second phase compensates for that. It becomes delayed, it's taller, it's protracted in response to that, and the result is that insulin curve, that endogenous insulin curve in the red dotted line, which is both elevated and flattened. So despite having higher concentrations of insulin throughout the day, as that red curve shows you, this patient actually has high blood sugars that still run high, particularly after meals, because of that loss of matching with the glucose in the food profile. I'll take the next slide. So if we tack on basal insulin, if we add too much basal insulin, if basal insulin is the only tool in our toolbox for dealing with this, well, you can see there's a clear mismatch between what the body needs and when the insulin is acting. Take the next slide. So that mismatch is illustrated in the area shaded in gray, and it's this mismatch that causes hypoglycemia and weight gain associated with basal insulin. Okay, so over-basalization. The big clue for that would be, for example, if someone comes in with early morning or fasting hypoglycemia when they don't eat. So if they skip a meal, for example, and they start to run low, you need to worry about that. At basal insulin doses higher than 0.5 units per kilo, over-basalization could be a concern. In fact, pharmacodynamically, there is some evidence that there might actually be an inflection point where each additional unit of basal insulin gives you diminishing marginal returns on glucose control at about 0.3 units per kilo. So that's your range. That's 0.3 to 0.5 units per kilo, where you should start to have your antennae up and think, okay, am I over-basalizing this patient? Am I doing what's appropriate to match what the patient needs during the day in terms of their insulin? And so over-basalization can be thought of as a product of too much intensification on one hand, so too much basal insulin on one hand, but on the other hand, it might be the product of waiting too long to intensify diabetes therapy further. And so classically, this meant waiting too long to put on the prandial insulin, which is much better matched to what they need with their food, for example, and focusing too much on the basal insulin. But especially now that we have new insulin sparing agents, I encourage you to think of this as also perhaps waiting too long on our patients who are on basal insulin to think about, wait a second, what other agents can we get them on that might spare them the need for insulin to begin with? Can we get them on an SGLT2 inhibitor? Can we get them on a GLP-1 receptor agonist? Okay, I'll take the next slide. So this is a tool from the Endocrine Society. It's just a simple series of 4 questions that might give you a hint. The tool was originally designed to point at the patient who, yeah, that's enough basal insulin. We really do have to think about prandial insulin now, okay, about intensifying therapy that way. But I encourage you to use it also as a way of thinking about, okay, basal insulin, maybe we're getting to the limit of that. Let's take stock, let's step back. What else can we do for this patient, right? And so the questions are, is the A1C still high? Is the basal dose above 0.5 units per kilo? Is the patient's fasting blood sugar at goal, but somehow the A1C is too high? That means the patient has postprandial hyperglycemia most likely. And are the patient's postprandial blood sugars above 10 in Canadian units or above 14 if you're willing to tolerate higher blood sugars for a higher risk patient, right? So those are your tip-offs that, okay, got to do something other than basal insulin now, right? I'll take the next slide. Okay, so for this specific patient, I totally agree with Donna. I'd stop the glycoside. I'd cut the glargine 50% down to 20 units, and I'd actually get the patient to take that during the day instead of the evening. Now, just a reminder, when you do ask your patients to change the timing of their Lantus doses, you do have to give them some specific instructions about exactly how to time their doses so they don't end up stacking their insulin doses and overdosing because they took a dose in the evening and then the next morning, for example. But for this patient, there's a large component here of education, I think, that's really important. I need to make sure this patient knows how to handle a low, knows what they are. So here are some resources. Rose, I don't know if we're going to show us the hypoglycemia handout. It's a good one. It's a gooder.
Yep, I'll go through it at the end.
Okay, sounds good. Sounds good. So we do have some handouts that are available. But don't forget as well, you're not alone in this. So put your patient in touch with a diabetes educator. It could be through your PCN. It could be through the pharmacy or through a specialized diabetes clinic. All right. So that's where I'll end my thoughts. And take it away, Rose.
Okay, thanks so much. What do I think about this patient and where to go with this patient? So as shout out to my dad who's watching, who has always encouraged me to think pathophysiologically. And I encourage you to think pathophysiologically about diabetes and think about what is causing this particular patient's hyperglycemia. So, the typical thing that we've been told is that there is an initial phase in type 2 diabetes of insulin resistance, and then over time, the beta cells peter out and we get insulin deficiency occurring as the disease progresses. So I want to think, okay, this lady is 64 years old and she's starting, she's had longstanding diabetes. Where do I think her endogenous insulin production sits now? The other thing that I always think about when I see a new patient is, am I convinced that this is actually type 2 diabetes? So doing that thorough history, understanding how the diabetes came to light, how long it's been going on for, and the type of course they've had is very important in understanding the pathophysiology. And all of these things are what are influencing my confidence to stop or reduce insulin safely. So to remind ourselves, when is insulin appropriate? Insulin is appropriate if the patient has ever had a history of diabetic ketoacidosis or beta cell depletion or absence. So if we have removed that patient's beta cells via surgery, for example, if they've had a Whipple's procedure for cancer, they must be on insulin because we need insulin for our background metabolic functions. And so we must make sure that we are not putting people at risk if they do not have a pancreas or type 1 diabetes affecting beta cell production. So the things that we can consider to look at endogenous insulin production is by measuring a C-peptide. And I'm going to talk about that more in a second. I think the other thing we need to consider when insulin is appropriate is if they are in severe metabolic distress, where they have symptomatic hyperglycemia. So this may be temporary. For example, if they have steroid-induced hyperglycemia, we may need insulin for temporary time while they're on steroids, and we may be able to take it off when they're not on steroids. In acute illness and hospitalization, we generally use insulin because it is the safest. With the understanding, for example, SGLT2 inhibitors require sick day management and can drive hypotension and dehydration, or we don't want to use these in the setting of acute illness. And finally, if nothing else is working, we use insulin. So this is the table from Diabetes Canada, just reminding us of how to distinguish between type 1 and type 2 diabetes. And I want to just also say that, the more diabetes I see, the more I realize these are buckets that we've created to try to best categorize patients, but they are not complete by any means. And we are understanding that there is increasing heterogeneity in diabetes. And you may have heard the terms like type 1.5 diabetes. But suffice to say, with type 1 diabetes, generally patients are younger. Generally, they are thinner at the onset of disease. But this is the caveat. Now that people are gaining weight, now that the public is 60% overweight or obese, many of these patients can present with overweight or obesity. Type 1 diabetes is also characterized by autoantibodies such as the GAD antibody. And the C-peptide, which is a reflection of insulin production, is usually low after a few years. So this is important to note because at the beginning, when they're first diagnosed, there can be some waxing and waning of insulin production. And so it's important to understand the time course of when one is testing these things and what is happening. We treat diabetes type 1 with insulin replacement. So this is a disorder of insufficient insulin, and so we are giving them insulin, and that is the most appropriate treatment. For type 2 diabetes, usually we are seeing it in older populations, but we now are seeing it in childhood and adolescence more and more, paralleling that rise in BMI. Most cases are associated with excess weight, but pointing back to the first talk I gave, this is a very personalized measurement, i.e., some people are just prone to this problem of excess energy storage at a lower weight. And we know, for example, Asian patients particularly will develop type 2 diabetes at a lower body mass index. These patients typically do not have autoantibodies when you measure them. And when measuring the endogenous insulin production, we usually see normal to high levels when they are earlier on in the course of the condition. Monogenic diabetes is stated here. Generally, this is a condition that occurs in the younger population. They look similar to the general population, but you may be triggered to think maybe it's not type 1 or type 2 if they aren't presenting with ketosis or aren't presenting with obvious signs of insulin deficiency, but they are slim and young. And further, if there is a strong family history, that may be another trigger to consider. They also have other unusual things like hearing loss that may make you think maybe something odd is going on. So I also want to point out the fact that even when we look at what we think is type 2 diabetes, so this is a study looking at type 2 diabetes where they looked at a number of diabetes patients in Sweden, and they connected the diabetes and did a cluster analysis based on their GAD antibody positivity, the age of diagnosis, BMI, A1C, and estimates of beta cell function. And what was really interesting was that they were able to parse out differences in phenotypes relating to the end organ complications. And so what this really tells us is that, yes, we know that there are heterogeneous differences within type 2 diabetes. And in this paper, they labeled them severe autoimmune, severe insulin deficient, severe insulin resistant, mild obesity-related diabetes, and mild age-related diabetes. And I think just seeing those labels, you think to yourself, yes, I've seen all these types of patients, and diabetes is very much not the same condition. So a word on C-peptide and autoantibodies when you may think that this is a person with type 1 diabetes. And I will tell you, I have diagnosed a lot of people with type 1 diabetes later on in life, in that they were originally misclassified. So there are quite a number of people out there who, have been labeled as type 2 who actually have type 1 diabetes. And so, one of the things that I forgot to mention was if they have strong autoimmune history, so for example, they've got hypothyroidism, maybe they've got a patch of vitiligo, maybe there are some other autoimmune conditions in them or their family members, that's another trigger to think, maybe I'm looking at a type 1 diabetes patient. So C-peptide, you can see here, the body produces proinsulin, which breaks down into insulin and C-peptide. And we like to measure C-peptide rather than insulin because it sticks around a bit longer, and the lab standardization for measuring C-peptide is better than for insulin. So we can measure this in patients where there's uncertainty of diagnosis and if we're worried about the risk of DKA by reducing their insulin. Now, one of the things I was taught by a colleague is called the Egg McMuffin test. So this is a stimulated test where we're stressing the pancreas to produce insulin. So what we say to the patient is, you can go eat an Egg McMuffin, and they love that part. And then we say, but you have to go do your blood work 1 to 2 hours after. And what you order is you need both a glucose and a C-peptide. And you tell the patient, I want your glucose to be above 8 when you walk into the lab. So you get them to check with the glucometer when they're heading to the lab to make sure it's higher. You may have to hold their mealtime insulin. If they are on mealtime insulin, you may actually even hold their basal insulin for the day of the testing to make sure that they're going in with a higher blood sugar. And in Alberta, widely available, anyone can order a GAD autoantibody. So family physicians can order GAD autoantibodies if you suspect that there is type 1 diabetes on a standard requisition. And family doctors can also order C-peptide levels. So I've included a slide, if this interests you, on the specific values that may trigger one to think about the different diagnoses here. But suffice to say, if it's less than 0.6, this is where we get nervous about reducing or stopping insulin. This is where I would suggest, if you're uncertain, please send a referral to a diabetologist to get an opinion about what to do with the insulin. Now, going back to the patient, I suspect that she just has standard type 2 diabetes caused by hyperinsulinemia, given her BMI and given what is happening with the weight and her disease course so far. So in a disease of hyperinsulinemia, the question is, does it make sense to give more insulin? And I think we've talked a lot about this with regard to putting her on the other agents. But I also want to point out the fact that when there were trials of intensive glycemic control, including Advance Accord and VADT, these huge mega trials did not show improvements in morbidity and mortality. And in fact, there was actually worsening mortality in Accord. And so there have been a lot of hypotheses that these negative or these neutral and maybe negative effects are driven by the actions of insulin. Because remember, insulin is an anabolic hormone, so it builds up muscle and fat, and it's a growth factor. So it promotes the glucose transport into the different storage organs, liver fat, skeletal storage, to increase fat synthesis, decrease proteolysis, and decrease autophagy. And remember, we talked about autophagy and your cellular spring cleaning. So it's decreasing that mechanism. I also want to point out that normal hepatic gluconeogenesis is impaired by hyperinsulinemia, but what we're seeing in type 2 diabetes is this is broken, is that the liver, because it has too much energy and it's facing an energy excess crisis, is spitting out glucose despite having lots of insulin around. And so this is important to note, because the underlying pathophysiology of this problem is, oh, there is increasing metabolic negative milieu. We've got increasing insulin, increasing glucose. The system is broken and the liver's not slowing down that glucose production. So to look for hyperinsulinemia on a patient, if you ever see skin tags, you can think, oh, is this due to the growth factor effect of insulin, particularly on the background of acanthosis, which is one of the skin manifestations of insulin resistance. Now, I also want to point out this paper that was actually published in the Canadian Medical Journal in 2009. This was a publication from my mentor, Professor Juliana Chan in Hong Kong, who at the time was looking at her patients with type 2 diabetes and looking at the interaction between C-peptide levels and insulin treatment. And in this series of patients, patients with low C-peptide levels on insulin had the best clinical outcomes, which makes sense. If they're insulin deficient, we are giving them hormonal replacement, they're doing well. Type 1 diabetes, some insulin, they're doing well. In patients with normal to high C-peptide levels, so these hyperinsulinemic patients, if they were put on insulin, they had the worst outcomes. So this, I think, really gets me to think, we have to think about what is going on in our patient. We have to start thinking about where they are in the insulin, endogenous insulin spectrum, and target that appropriately. So I'm going to pass it back to Donna to talk about the follow-up of what happened to this patient.
Yeah, so you can see things have improved quite a bit. She's lost a bit of weight, and her blood sugars are much better, right? Both the hemoglobin A1C, and you're not getting the lows in the morning. However, it's not great, right? I mean, she'd like to lose a bit more weight, and things aren't great, so with her, she's on, I put her maybe on canagliflozin, probably a low dose, like 100 milligrams. I really wouldn't want to increase that. I often see more side effects with that, and maybe Rose and Darren can comment on that, but I often have people that stop because of yeast infections and go to the lower dose. And I don't think there's a whole lot of benefit increasing, but she could do well with something like semaglutide. Her blood pressure is actually really good, right? And it's come down. She's on a hydrochlorothiazide, which I don't think is great. I think we could stop that. She's probably been seeing the dietitian and, maybe our diabetic nurse as well, and doing a good job in altering some of her lifestyle, which hopefully she's getting more vegetables and less of the processed things, so we'd encourage her to follow through on that. And you can take it away.
Yeah. So my first thought, revisiting the case, is, well, the average blood sugars are still about 10, and they were 10 before we started, and that is consistent with an HbA1c of about 8.0%. So it started with 8.0%, now it's 7.8%. But still, even though we really haven't changed her average glycemic control, I consider this to be a huge win. And the reason is because she is on less insulin, she has lost weight, she is on an agent now with end organ benefit, she no longer has low blood sugars, her glycemic variability is much better, and she feels better. So this is definitely a win. And I'm going to use this opportunity for positive feedback to celebrate this win. I'll take the next slide. Of course, to have an idea of what the goal should be, we need an individualized A1C target. So this slide is just a reminder, okay? Take account of patient context, take account of the options you have available in your armamentarium. It's very different for a patient who's on insulin and having lows versus a patient who is on metformin and hasn't tried anything else, in terms of your concern about going after lower A1C targets, okay? In this patient, despite her low blood sugar, I think it's still reasonable to try for an A1C of 7.0%. She's relatively young. She's still got a lot of function to preserve, and we haven't finished exploring insulin-sparing agents here, and there's still some benefit that might be had from weight loss. Of course, it's a good thing we dealt with the glycemic variability and the hypoglycemia first, because you can really only go after A1C reduction once you address low blood sugars for safety reasons. Safety always comes first. I'll take the next slide. So I think Donna was hinting that semaglutide would be an excellent option for her. I totally agree. I think semaglutide would be the next go-to. There are some practical considerations here because she's under the age of 65, no longer working. So your social worker might be your new best friend. I think I might interact with my social worker more than I do with my dietitian, quite honestly, for a lot of the patients I see. All the SGLT2 manufacturers do have compassionate access programs. 100% gives you a free SGLT2 supply. Unfortunately, no such program exists for semaglutide now. But later, Dr. Yeung, if we have time, will teach you a dose and trick to give you a bit of a cost savings if you do have patients who are paying out of pocket for their semaglutide. But another point I'd like to make is that this is an opportunity to enlist the patient because she's feeling good now. And the goal of reducing or even getting her off of insulin eventually might really resonate with her. So now's the time to say, hey, this is progress. We're really moving forward. You're on half the insulin dose you were on before. So let's get the rest of the house in order. So let's work on that diet, that physical activity, and other CV risk factors as well. All right, pass it back to Rose.
So I think this is well covered in terms of the fact that A1C does not reflect the variability in her glucose. A lot of the time, patients will come to the clinic without data. And I think this is really the message to say, this is where we need to help negotiate with patients and get some information if they're not forthcoming. You may need to enlist, your chronic disease nurse if you've got one, or your diabetes educator who's working with them. These are things that you can work together as a team to obtain that glucose. A big thing is the frequency, utility, and cost of testing. Many patients are testing the same numbers. So they're they're checking their fasting blood sugar every day. And it does nothing for them because they never change their dose. They never adjust. They never think about it. It's just some rote thing that they do every day. And I want to encourage you to monitor with meaning and think about how much you want to get that individual patient to test and how that's going to change behavior, right? We're encouraged in medicine not to test if it's not going to change our behavior. And I really want you to address this with patients or have your team address it with patients if they're just, using test strips up, but really not changing anything they're doing. Glucose monitors, continuous glucose monitors are now part of the tech we have available. Unfortunately, they are very costly and usually only covered on private insurance. There are compassionate releases for people who are having a lot of extreme glucose variability, who are having difficulties with adjusting their insulins. But generally speaking, these are available for people who have existing coverage. But they are incredibly useful. As one of my patients put it, it's like driving a car and having the windows blacked out, and your glucometer test is, having a picture of the road every so often to guide how you're going to drive that car. Whereas having a continuous glucose monitor, which gives you readings every 5 minutes, is like unblocking the car windows and being able to see the road and to navigate. Now, these monitors here, this is the Freestyle Libre. Most of you are probably familiar with this little, toonie-sized sensor that lives in the arm for 2 weeks. You can read to this reader, or you can read to a smartphone. And what's really great is that now with the smartphone technology, they can send you the sugars via email, or your clinic can download a program called LibreView, and you can actually invite them to share their sugars and have that data available at clinic visits. This is the Dexcom continuous glucose monitor. It's more expensive and generally reserved for people with type 1 diabetes, but I just want to put a plug out there for patients who are on multi-dose insulin, in particular with type 1 diabetes. Please ensure that they have access to these things if possible. With regard to starting more drugs on a patient on insulin, and in this case, with our patient who is interested in starting a GLP-1 receptor agonist, if I'm nervous, I go slower than the standard recommended doses. So I just want to show you here. This is a sample pen for semaglutide. And what you can see is that there are a lot of clicks. So from 0 to the first dose of 0.25, there are 19 clicks. So if you are worried about them tolerating the 0.25 off the bat, or you're worried about inducing hypoglycemia, you can actually tell them to start at 10 clicks or 5 clicks. They can count, or they can mark it with a Sharpie and start at a much slower rate to titrate more easily. I often will start half-dose SGLT2 inhibitors on people who are afraid of hypoglycemia. People tolerate it very well. And then it gives them a bit more buffer to adjust their insulins. Donna had pointed out the algorithm about adjusting insulin. You know, my rule of thumb is don't reduce if you're starting above target with no hypoglycemia, but you can consider 10 to 20% reduction when you're starting a drug. And please remind that patient to be prepared for hypoglycemia. And I wanted to take a quick moment now to show you some resources that you have access to via the Edmonton Diabetes Resource Working Group. So if you go to Google and you put in Edmonton Zone Diabetes Resource Working Group, it will bring you to a number of resources we created. So this was created in conjunction with a number of diabetes educators from across the zone. And I'm very grateful to them for coming together to review the existing materials and create new ones. Because basically, when I started practice here and we started this working group, we got the educators together to look at how many resources they were using. And there were over 200 resources that people were using. And so what we did was we consolidated and took some of the ones that were the most used and updated them. And then we had to create new ones. So the one that I think is very useful is the Hypoglycemia Basics resource, which explains why and when it happens. It has nice little graphics to remind patients about this and tells them how to treat their lows properly. So it's the rule of 15s, 15 grams of fast acting sugar, wait 15 minutes and retest. And if it's still less than 4, you have to treat it again. If it's more than 4, you need to eat. And then gives them directions about taking in a meal or a snack, depending on when their next scheduled food is. Another very useful resource is this site on SGLT2 inhibitors, insulin, and DKA. So this is available to go through with a patient. So you can write in and customize this for the patient. So it goes through the explanation of what's happening without SGLT2 inhibitors, with SGLT2 inhibitors, and introduces the symptoms of diabetic ketoacidosis to watch out for on days that they are ill. We then also give recommendations about measuring ketones for people who are at higher risk of ketosis, and give suggestions on how much rapid acting insulin to give for fixing the ketones when they're sick. So this is really for people who are on basal bolus insulin, but it is a useful handout to have to remind them how to treat themselves when they're unwell and to stop taking the relevant medications. So it's a more detailed tool to use than the standard SADMANS tool. Okay. So we'll go back to the presentation here and just give some summaries. So for patients on insulin, we need to ask about hypo and hyperglycemia symptoms. We need to recognize the safety aspect of the hypoglycemia before adding on new agents and really get a good idea of what's happening with the blood sugars and get them to monitor with meaning so that they're monitoring to help with adjustments and to help understand what is happening with the medications. In patients who have really long-standing diabetes or who have, different phenotype or, you wonder about insulin deficiency, we've given you some tips on how to measure C-peptide, make sure that a random glucose always accompanies that C-peptide and that you're aiming for a higher glucose than 8 when you're measuring C-peptide. If you're worried about insulin deficiency, don't feel comfortable with the testing, please do refer on. And if you're fairly certain this person is hyperinsulinemic, you can consider adding on 1, 2, or both of these newer agents and to do close follow-up. And by close follow-up, we've got patients who are seeing team members on a weekly basis or even sooner, maybe every few days, depending on the lability of their blood sugars and whether we're worried about their lows. So we want to also lastly promote healthy behaviors and give hope. And we will open up. I notice we ran a little bit over time, but we are open to questions and comments.
Thank you to the speakers for such an amazing presentation. And we have some great questions here. I don't know if we'll be able to cover all of them. And by all means, people, our participants, if you're willing to stay, then we'll hopefully be able to answer most of them. Just before I forget, I want to make sure that we call everyone's attention to the evaluation form that you can access through the QR code that you can see here, or through the link that Nandini has actually put down in the chat box. So just keep that in mind. And then also, it'll probably show up, there it is. In terms of getting involved with lifelong learning, we'd love to have you involved. And we would love to do some co-creation with you. So please scan this QR code as well if you're interested in participating. And we also have the URL there. Nandini has also put that down in the chat box. So if any of you are interested in being a part of some really cool endeavors, then I would definitely encourage you to participate. I know Darren had actually answered a few of the questions in the Q&A that were relating to weight gain and insulin and whether or not it's reasonable to switch to an SGLT2 or GLP-1 agonist. But I actually wanted to call attention to one of the questions that had come up, and I guess, Rose, if there's a patient with diabetes and renal failure and they don't want to go on an SGLT2 inhibitor because of past genital and specifically yeast infections, are they all similar in terms of mycotic infections? And could he or she try giving them diflucan or a topical anti-yeast at the same time?
Yeah, so it is a class effect. We see similar rates of yeast infections across the different medications. But I would say that perhaps starting half dose would be a consideration. So you can start half dose and see if the patient has problems. And given they had yeast infections on one type, I would change it just so that, you're saying it's a different molecule. Maybe you'll have a better reaction to it. I generally use the 3 strikes you're out rule. And I say that if you've had 3 yeast infections and it's not getting better and you've tried half dose, then I don't think that it's a very good medication for them. So those are some of the limitations for sure.
I was actually just on that point of CKD and half dosing. I know our particular example patient we had on 100 milligrams of canagliflozin, and that's because the labeling of canagliflozin with eGFR below 60, the recommended dose is 100 milligrams actually. But that particular dose decrement labeling doesn't exist for the other SGLT2 inhibitors. This is a little bit off topic from the question, but I thought I'd raise it as a dosing point, just in case folks didn't appreciate that. So dapagliflozin, for example, you're safe to use 10 milligrams actually further down. That was the dose they actually used in the DAPA-CKD trial. Anyways, just a quick point on dosing now that that point's been raised. Yeah.
And I do want to point out that in the trials, you know, this relates to one of Donna's comments earlier, is that when they looked at the dose comparisons between the lower and the higher doses of the SGLT2 inhibitors, clinical efficacy is actually not that markedly changed by the dose. So going to a higher dose often does not result in better glucose lowering. So that's something to keep in mind.
Yeah.
Not everyone's the same, but in general, we're not really seeing huge improvements with increased dosing.
Yeah. And I've had patients that couldn't tolerate the higher dose and were good on the low dose in terms of yeast infections. It was usually the men would have some symptoms, but not enough to need to quit the medication.
I think it's just worth bringing up and hopefully quickly. Darren, Rose, or Donna, would you get accurate C-peptide levels for someone on insulin? I would think that C-peptide levels will be suppressed if you're on exogenous insulin. It can result in false low C-peptides. I think you guys had just sort of mentioned something to this effect, or sorry, you had spoken about this in one of the slides, and maybe just a bit of clarity on this.
Yeah, sure. So I reviewed the literature on this, and if a person is in fact hyperinsulinemic from type 2 diabetes, you're not going to see so much suppression. But like I said, if you're worried about it, you can hold the insulin for the period before going for the test. And I will reiterate, we're aiming for a glucose of above 8. So even if you do it fasting, you want that blood glucose fasting to be above 8 when you go get that test. Because you have to think, I want to see what is the pancreas doing when the blood sugar is high. Is the pancreas appropriately producing insulin when the glucose is high? If yes, okay, we still have endogenous insulin production. If no, maybe we have deficiency. But generally speaking, for patients with type 2 diabetes, if they're hyperinsulinemic, you will see that on the C-peptide, and it's not going to affect that part of it.
Getting into a bit of the counseling, and Donna, I'd love to hear from you on this. Since SGLT2 inhibitors and GLP-1 can both reduce insulin requirements, how do you counsel patients who are already on insulin? Do you recommend them to reduce their insulin by a certain amount or percent to avoid hypoglycemia on initiation? I know Rose talked about how much to reduce, but if you had any comments on sort of the counseling that you might end up doing with patients, especially from a primary care perspective, I think that would be valuable.
Yeah, I would really want them to be well educated about hypoglycemia and to monitor for that. So again, sometimes you don't have time, to do that. So I might bring them in to see my diabetic nurse actually and go over that. If you have time, going on the website and pulling off some of those resources are excellent. I really like to go slow. So the pen clicks would really appeal to me. And I'd go really slow, so a lot of the lowering would depend on, what sort of blood sugars they have, where are they? And I'd want them monitoring the blood sugars, so often there's a problem where they're not, right? So if I'm changing, they have to be monitoring their blood sugars as well, right?
Yeah, there's no, I haven't encountered anyways a hard and firm guideline. And I think it's very different if your patient is on insulin and has an A1C of 9% versus one who's on insulin and has an A1C of 7.4%, and you're putting on additional agents because they've had a heart attack in the past, so you want the end organ benefit. And so the patient who's got an A1C of 9% and their home blood sugars corroborate it, they might not actually need an insulin reduction, right? They might be running pretty high most of the day. So it's very contextual, and perhaps the best advice is, as Donna says, is that close follow-up, that good education piece, and making sure they're linked up to resources to self-manage a little bit, right? Because patients do need to go home and respond to symptoms and adjust their insulin doses a little bit on their own if they need to. Yeah.
I had a patient who's, I think his hemoglobin A1C was around 14. It was, but this is a guy, he's blind. And again, there's problems because he can't see his sugar, like he can't test himself, and his wife has schizophrenia, so it's difficult. And he uses he's using basal as well as mealtime, same dose, so it can't really adjust it. It's just all loaded and he's doing it same dose. But his sugars were so high, and I put him on, I think it was an SGLT. And I was surprised at how low, he didn't have any reactions, but I was surprised in 3 months how much lower they were. And his hemoglobin A1C, I think, is around 8 now or something. So it was substantial, but it changed, his lifestyle changed too, right? Because he's eating better. I think we cut the beer down and the cookies are less.
Someone's asking about hints around coverage. I know I was very curious about that too, Rose. Donna and I always have conversations about how we can try and massage the truth a little bit in our applications on Alberta Blue Cross, but I would love to hear from you about that dose reduction that might actually help out.
Sure. Am I able to share screen? Because then I can show you the resource that I find very useful. Okay, so this points to people who are paying out of pocket for GLP-1 receptor agonists. Let me just get this open. Okay, so Dr. Elliott has actually come up with a good handout on this. And basically what it says is that the semaglutide pens come in 2 doses, 2 sizes. And so if you ask the pharmacy to dispense the larger size, but you put them on a low dose, because the pharmacy will automatically give them the smaller pen if you put them on a low dose, but it's the same price. So the small box and the large box of semaglutide cost the same. Okay, so if you get them the large box, but you put them on a low dose, you have to inform the pharmacy you specifically want the large box. Following what I'm saying? So that you actually half the price of the semaglutide. So I'm trying to find the tool that I use generally.
Yeah, I wonder if it depends what company they have, what insurance company, because I've had trouble with Success with the larger pen, because it was seen as being for obesity versus diabetes by some companies where they were charging more. So it might depend on the insurance. It's been a real pain because I always have to talk to the pharmacist about each patient and what they have covered.
Ozempic, because the obesity form of Ozempic isn't available in Canada, but is expected in about January. I don't know what they're going to market it as under, But for diabetes, Ozempic, the 1.0 milligram, which is the max treatment dose, that kit is different from the 0.25 to 0.5 dosing kit. But the pens are actually exactly the same. It's just the 1.0 dosing kit comes with 2 pens instead of 1 pen. And the pens in the 1.0 dosing kit are only marked for the 1.0 milligram dose, as opposed to the pens in the lower dosing kit, which are marked for the 0.25 and 0.5 milligram doses. So what Rose is saying is you prescribe the 1.0 milligram dosing kit, which comes with 2 pens instead of 1, but the patient takes 0.5 milligrams, and then you get 2 for the price of 1. It's still $100 though. It's still $100 out of pocket, so it's still quite expensive, but better than 200.
Yeah.
And do pharmacies go along with this?
I've never had a problem doing it myself.
It's I see it as sort of akin to some of the antidepressant medications where you go to a lower dose pill and it costs the same amount as a higher dose pill, right? You know, so some drugs are like that, and you can cut them in half, and you know, get the higher strength and cut it in half, and people save, you know, half the cost. It is a problem with pharma for sure, and we're not informed sometimes by the pharmacist who would know this too.
Yeah. So I was having difficulty finding it because Dr. Elliott has updated his resource to a different site, but he does mention it here and says, you know, on the prescription, you just say semaglutide 1 milligram weekly or as directed, and put specifically dispense the 4 milligram pen. And then that's where you get the biggest pen dose for the equivalent cost of getting a 2 milligram pen.
Yeah, I think if I can just interject here, and if the physician will write the prescription as the 1 milligram dose, the pharmacist will be able to dispense that, and the insurance should pay for that.
Yeah.
Now, the important thing to point out here as well is that the 1.0 milligram dosing pen is not marked at the 0.5 milligram dose. So patients have to learn that click counting technique. You got to do that 38 clicks to get to the 0.5 dose. Once they do it once, they can grab a Sharpie and mark it, then it's good forever, right? But it's a little bit, you do have to teach your patients how to dial in off-label doses using the bigger dosing kit. Otherwise, my only other tricks really are the social workers often spend a lot of time figuring out, making sure that patients get all the benefits. I'm always surprised. I had a patient I referred to my social worker for the diabetes medications, and what are they working on right now? Getting this patient a new furnace. Apparently there's a program he'd benefit from. So I love it.
Well, just go over some of the answered questions because I think there's some confusion in the chat. Can we just clarify the max dose of injectable Ozempic? I think someone had a question about that, Rose, and I think you'd answered it.
Yeah, so right now, the recommended dose is one milligram weekly. It has been tested in clinical trials at other doses, but currently the indication is 1 milligram per week. Does anyone want, Darren, do you have other thoughts on that?
So we're going to, again, come next January, we're going to see, Novo Nordisk anyways is hoping to have on the market the obesity formulation of semaglutide. That will go up to 2.4 milligrams, okay? Obviously, you just cannot dial in doses that high with our current pens. Like you'd be exhausting supply really, really fast. Unfortunately, we appear to have a very bad track record for getting obesity medications funded in the public system. So I don't know if Blue Cross is going to pick it up. It might still be something that's reserved for people with private, other insurance, right? But actually, honestly, the results from the STEP trials were pretty spectacular for this super high dose semaglutide for obesity. So I really can't wait until it shows up on the market, actually.
Liraglutide is available for obesity. I've been using a lot of it. Ozempic, I've tried both the oral as well as the injectable. A lot of times it's not covered. It's the liraglutide pens, because the higher dose pen, sometimes the obesity drug Saxenda is more expensive than the diabetic formulation, and I'll use the diabetic one in my obese patients to save funding. But it all depends on, you know, what the drug companies cover and what their plans are. It's a pain.
And Darren, again, just to cover our bases, you've answered the question in the Q&A, again, just with regard to, is it Rybelsus, I think? Somebody had commented on an oral Ozempic version, which I assume is Rybelsus, or so semaglutide. Did you want to comment on that?
Yeah, I think I had a slide last talk where it was the head-to-head trials of the various GLP-1 receptor agonists. And what we tend to see is that the best weight loss is with semaglutide, whether it's injectable or oral. And in fact, one of the pioneer studies was a head-to-head trial of Rybelsus versus liraglutide, Victoza, in patients with diabetes. And although the A1C lowering of the two agents was about the same, Rybelsus, which is oral semaglutide, of course, actually had a superiority in terms of weight lowering. So, you know, kudos to Novo Nordisk. It takes a little bit of gumption to run a head-to-head trial, cannibalizing your own medication, right? Because they're both Novo Nordisk manufactured medications. But yeah, I do expect pretty decent weight lowering under ideal conditions, though, with Rybelsus. Just a reminder to everybody, if you're prescribing Rybelsus, on the monogram, because of the mechanism of action, it doesn't need to be taken on an empty stomach, 30 minutes before food. And so I'm still waiting to see the real world evidence to know if it's going to be as effective as what we see in the studies. And again, there is no CV labeling for Rybelsus. So if you have a patient who does have a CV indication for a GLP-1 receptor agonist, I strongly encourage an injectable version instead.
Yeah. I have a number of patients with obesity that I've been able to use the oral on, and it's looking good if I can get coverage. Sometimes I can't.
Can I answer the question about blood sugar monitoring on oral medications?
Yes.
Okay, so the question is, if a patient is on insulin, they need blood glucose monitoring, but what if they're on multiple oral medications? So I would be in favor of blood glucose monitoring to understand and help the patient understand what is happening to their sugars in relation to activities and food and medication. So you may hear other people say, well, if they're not on insulin, there's no need to monitor. And I firmly disagree with this, because monitoring is biofeedback and it changes behavior. And if it's going to change behavior, then it's worth doing monitoring. And this is where, you know, even though things like the Freestyle Libre are not covered for most patients who are not on insulin, even with private insurance, I will recommend, if that patient can afford it and I think would benefit, I would say, you know what, instead of poking your finger 4-6 times a day to really understand what's happening with your blood sugars, maybe you can just get one of these sensors for 2 weeks and really understand what's happening. And people make remarkable changes. They really start to understand what foods spike their glucose, what foods keep their blood sugar stable. And that is one of the most beneficial parts of these continuous glucose monitors, because they give that immediate feedback and it's not this guessing game. And then you also get a very good idea of what's happening overnight. And if you're missing hypoglycemia, because if somebody has hypoglycemia unawareness and is sleeping through their hypoglycemias, you will see it on the monitors. So they are really useful tools. But if they can't afford it, still sticking with the standard monitoring, very useful. I like to tell people to do before and afters. So instead of doing the fasting blood sugar every single day and not adjusting anything, I say, why don't we do before and after one meal a day, and you pick the meal and you see the effect, and you record it and you record what you're eating, and we can review the patterns. So that's how I counsel people about monitoring.
Just a note on the Freestyle Libre. So I think that sensor for 2 weeks retails for about $80 to $90, and the reader itself is about that much. And so to start someone on it for 2 weeks would be about $180.
Well, the reader's $50. The reader's $50. The sensor is $90 if you get it at one of the cheaper pharmacies. I know some pharmacies are marking it up a little bit more. But if a patient has a smartphone, they don't need to buy the reader. They can just calibrate with their, or not calibrate, they can just link with their smartphone and scan with their smartphone and save that $50.
The other resource is the manufacturer offers a webinar. As long as you sit through the webinar, they will mail your patient a free reader and a sensor. So that's a decent starting package. That's a decent value. And that might be just enough to get that 2 weeks of data if you're complicated patients where you're really wondering, okay, what is going on here?
Oh, I like that, Darren. That's a good piece of information. We have a bit of a tangent for question-wise, but still quite relevant, maybe not necessarily directly relating to the talk today, but patients who don't respond as expected to SGLT2 or GLP-1, but with an ANC staying around 7.5 to 7.9, they're already on metformin. What are some options for next steps? Would love to hear from Donna on this one.
Cookies and beer could be a problem. So often we look at putting meds on things and we don't really look at what are they doing in terms of diet and exercise. Is there some other stuff going on? Are they on some other medications too? Like maybe their steroid for their polymyalgia is affecting, so you have to look at the whole picture. So it's difficult for me to really comment on this particular case without a lot more detail here.
Yeah, and I think, the reality is that there are going to be a number of patients who don't get to so-called target A1C on those two agents alone. And if you've done your bit with healthy behavior counseling and modification, and they're still hyperglycemic, the first thing I would look at is the patterns of hyperglycemia, because once again, can we do anything about the activities around influencing the patterns of hyperglycemia? If we're looking at pharmacotherapy, then we need to look at other agents. So, is this now time to reconsider pioglitazone? Is this now time to reconsider a little bit of insulin? So these things, I think, Darren, what would you be thinking about?
Yeah, exactly that. And I'd be trying to think phenotypically as well. We do have some phenotypic data in terms of bucketing people into groups that, for example, obese women with high degree of insulin resistance might actually be the perfect person to put on to give a trial pioglitazone to. Understanding, of course, the side effect profile of pioglitazone, the counseling that needs to go around that. I occasionally have patients in this scenario who refuse to go on insulin, and I'm sort of trying to get them to that point where they're ready to make that step. And sometimes I do end up temporizing with either glycoside, or if they actually have a primarily postprandial glucose excursion, which I see in a lot of patients actually, I use repaglinide. So I do go to these old agents if I have to temporize for financial reasons, and in the subgroup of patients who just phenotypically seem to do very well on these agents.
Acarbose is another good option because it's weight neutral. It can cause a bit of GI issues. So people can report like flatulence, bloating, diarrhea. It's used very heavily in Asia. Acarbose is one of the staples for treating diabetes in Asia. We just, for some reason in North America, culturally hasn't really taken on very much, but I think acarbose is a good agent that we often forget about.
It's one I like. I use it quite a bit when I can't use the others. But the main problem is the gut stuff I get, and it can really help with carbs, right? Because, they learn to
preventing the absorption. So it prevents the absorption of those short carbohydrates, and then they go on to the bowel for fermentation. So that's why people get the gassiness, etc. Bit of carb, it will encourage carb aversion.
Exactly. I found it helpful with the diet work.
There's an interesting one here. And they asked this. They don't remember if this was mentioned, but do they know why Ozempic is not indicated as a weight loss drug at the moment when it could be because of the weight loss associated with it while taking it for diabetes management? Maybe Darren. I'm assuming this has to do with the trials or how the companies have marketed it.
Yeah, so for it to be marketed as a weight loss drug in obese individuals, you need to have a trial where weight loss is the primary endpoint, and you need to have a trial where the population is full of obese patients, essentially. So it needs to be a trial that's very specific for that to achieve that indication. And so those would be the STEP trials, which were just published in some pretty high-ranking journals. And so because of that, we're going to start seeing the semaglutide indication for obesity at the higher doses showing up in the next year or so. Obviously, in the States, it's going to show up sooner because the States gets everything before we do. Boo. I guess it's just a bigger market, right? And but anyways, weight loss has been a secondary outcome in the diabetes patients, and so it's the primary indication. The indication actually is for the end organ benefits and for diabetes control.
And then there's a there's a one that has nothing to do with sort of diabetes, but if any of you guys knew, it asks, is diflucan safe in renal failure? And I believe it is. It just depends on the dose.
If the creatinine clearance is less than 50 mils per minute, you should reduce the dose by 50%. That's on up to date. So I'd be hesitant.
Oh, what's the lowest GFR that you'd feel comfortable starting Ozempic? This one just showed up.
What's the monograph now at, Darren?
Yeah.
That's a good question. You know what? I'm going to look it up right now. But in practice, I like Ozempic because it, along with a small handful of other agents, are great right down to dialysis. I'm just going to look up to make sure I'm not contradicting the actual monogram. But anyways, you know, what are our options in our patients with advanced CKD, right? You got insulin, you got repaglinide, you got linagliptin, and you got Ozempic, right? So those are, I actually, there's a very good niche for Ozempic in patients with very advanced CKD where they're followed by a nephrologist and they're getting pretty close to dialysis, actually. But anyways, here we go. Here's the, just to let you know, the renal dosing. Mild to severe renal impairment, no dose adjustment necessary. Hemodialysis, though unlikely to be dialysable. No supplemental dose or dose adjustment necessary. Used with caution due to limited clinical evidence. So there you go. Technically cleared for use.
Yeah, until more evidence.
Yeah. I find in that population, the thing that limits use is the nausea because they're already not feeling great. So that's one of the challenges. Yeah.
Well, we are all out of questions. What an awesome cap to an awesome series on diabetes. Once again, I thank all of the presenters who have been here from day one. Thank you to all our participants who were able to join us, and we appreciate your feedback. So please make sure you have an opportunity to click on the QR code or on the links here for both the evaluation and co-creation. And we look forward to seeing you at a future session.
Thanks, everyone. And do let us know what you'd like to see from the Office of Lifelong Learning in the future and the Physician Learning Program.